Ciao.
Okay, good morning, good afternoon, and good evening, everyone. Bonjour and bonsoir. I'm Bobby Staninovich. I'm a neurosurgeon from the University of Buenos Aires Hospital, and along with Dr. Rodolfo Recalde, a neurosurgeon, and Dr. Diego Prost, a neuro-oncologist, we are going to coordinate today's webinar. Also, we have a panel of experts neurosurgeons that will contribute to the webinar. We have the pleasure to have Professor Armando Basso, and from Uruguay, Fernando Martinez Venia, from Argentina, Doctors Álvaro Campero, Andrés Servio, Maximiliano Núñez, and Gustavo Troccoli. Today we have the pleasure and honor to have as a speaker Dr. Hughes Duffau. He's a worldwide known brain tumor surgeon. He is the professor and chairman of the Department of Neurosurgery and director of Team 4 INSERM U1191 Institute of Functional Genomics at the G.D. Juliac Hospital in Montpellier University Medical Center, France. So huge welcome, thanks, and we are anxious to hear you.
Thank you so much, Roberto, for your kind invitation. I'm very happy to have this opportunity to give us some new insight into low-grade glioma surgery, and especially to prune this Connectome-based surgical approach, especially in patients who benefited from awake mapping. The goal is clearly now to increase both the survival and the quality of life, but it's not just a goal. This is achieved in the past 25 years. Definitely, we know now that it's possible to give the opportunity, as you will see, for patients with low-grade glioma to live longer, but also to enjoy normal life. To achieve this ambitious goal, first of all, we decided to do early surgery, preventive surgery, including in incidental low-grade glioma. So definitely the wait-and-see attitude should be abandoned. Second, the goal is to do an extensive resection, because we know that the extent of resection is correlated to survival. So if we can achieve supratotal resection by taking a margin around the flare abnormality, we have to do that. And third, of course, we have to preserve the quality of life. And this is the reason why, at least to my opinion, intraoperative mapping is really mandatory. And we have to understand the function of the connectome for each patient at that time in order to do a surgical resection according to the individual functional boundaries. I will not too much insist about the natural history of low-grade glioma. I'm sure that now everyone agrees with the fact that this tumor is not stable, that it will grow in other cases, it's not benign, it will become malignant, and finally will induce a permanent deficit and will kill the patient with survival between 6 to 7 years. But we have to insist on the fact that these patients, the vast majority of cases, they are well, they enjoy my life, they had seizures, they are not so well. And we have to do a very extensive cognitive assessment before any treatment. And if you do that, you will see that in more than 80 to 90% cases, they are not so well. They have some cognitive disorders, modification of the behavior, and so on. And you can tell me, so it's related to the location of the tumor, and I will answer, not at all. It's not in a localizationist view of brain processing. It's related to the fact that the tumor invaded the connectivity, the white matter tracts, which had a limitation of the neuroplasticity. And this is the reason why it's very important to understand the human connectome to be a brain surgeon today. Otherwise, we will not predict how we will be able to remove the tumor and how we will be able to preserve or even improve the quality of life of the patient. Indeed, brain plasticity is absolutely critical for this patient with diffuse gliomas, and especially to preserve the quality of life, because there are nonetheless some limitations. And the first step, meaning that the brain reached this limitation of connectivity and brain plasticity, is in fact seizures. So to speak about some oncological considerations, everyone knows that the volume of the tumor is critical when we do the diagnosis, because more the tumor is big, more you have a risk to see malignant transformation and then to see a decrease of the survival. It has been demonstrated by Mitchberger in San Francisco 20 years ago, and we replicated these results about more than 1,500 patients with low-grade glioma in the low-grade glioma consortium in France. But also we introduced the fact that if we have time, which is the case in the vast majority of patients with low-grade glioma, it's very important to do 2 MRIs with 1 to 2 months apart before to go to the operating theater in order to calculate objectively the volume of the tumor, but also the dynamics of the tumor. And it's very exciting to see that if the tumor is growing faster, of course, the prognosis is worse. It's just an evidence for the vast majority of patients, but it's not in the guidelines written for and by neuro-oncologists. So we would like to insist on the fact that this growth rate is not related to the molecular pattern of this tumor. We published in neuro-oncology, for instance, so that you can have tumors with IDH1 wild type with a very slow growth rate. And in these cases, what we did is to avoid to administrate systematically adjuvant treatment following extensive resection. No chemotherapy, no radiotherapy. We published this paper 2 years ago in Journal of Neurosurgery, and you can see that 84% of our patients were still alive with more than 7 years of follow-up without chemoradiotherapy. So that means that molecular biology is just a part of the history, but should not be the absolute backbone pushing you to do chemoradiotherapy. In all cases, the most important is first of all to do surgery. Indeed, you know probably these 2 papers in the literature with very honest findings demonstrating that if you do just biopsy, definitely the median survival is 6 to 7 years despite chemoradiotherapy. But in our series, based on an extensive resection, but also an objective calculation of the volumetry before and after surgery, we demonstrated that the median survival in a prospective study is more than 15 years. So that means that it's more than the double in comparison with the classical series with just biopsy, independently of the postoperative adjuvant treatment. And the secret is that we have more and more tendency to reoperate the patients because, of course, now I have more than 20 years of follow-up, and I'm not able to cure patients because it's a diffuse glioma. But more and more, I can do a second, a third surgery thanks to mechanisms of neuroplasticity occurring in the meantime, and then to decrease again the residual volume, to decrease significantly the risk of malignant transformation, and to increase significantly the median survival. So everything is really logical. We have not to do biopsy anymore, except in some occasional cases of gliomatosis, like you cannot remove the hemisphere, of course, but otherwise, no reason to do a biopsy. We have to do an extensive resection according to functional boundaries, so definitely to understand the connectome of the patient at that time. And to do that, we need mapping techniques before and most of all during surgery. Indeed, the vast majority of these tumors are located within the so-called eloquent areas according to a localizationist view of brain processing. And you will see that during this talk, as usual, I will burn localizationism. And we did that recently by publishing the Bible of human physiology, physiological reviews, the fact that localizationism does not exist. This is the reason why we can operate in the so-called Broca's area, the Wernicke's area, the central area, with more than 99% of reliability because the brain is organized in networks. And you will see at the end of this talk that now we develop the concept of meta-network, network of networks, explaining why plasticity is so important. So to better understand these mechanisms, we can use a functional imaging. I am PhD in functional imaging, and this is the reason why I can tell you, I have the regret to tell you that at the individual level, functional imaging is not reliable. It's true for fMRI, it's true for DTI. Why? Because you can see the sensitivity and specificity of fMRI when you compare it with the intraoperative cortical and subcortical mapping. So you cannot make any decision based on this poor reliability. It's not my view, it's just objective. Second, we did the same thing with resting state fMRI. Definitely, I am involved in functional imaging for 20 years, and we demonstrated by comparing with the intraoperative cortical mapping that the reliability was around 85%. So that's beautiful in order to do research and to do systematically fMRI before and after surgery, as I will show you to better understand mechanisms of brain plasticity. But into the operating theater, I cannot make any decision to stop the resection or not according to a methodology with the risk to induce permanent deficit in more than 15% of cases. So we have to awake the patient, because this is exactly the same thing at the level of the white matter tract using DTI. It's not my view. I know that the reliability is less than 20%, because it has been demonstrated by experts in this field very recently, 3 years ago. They demonstrated that the tractograms contain many more invalid than valid bundles. How do you want to make any decision or to stop the resection during surgery according to this kind of methodology? So please awake the patient, exactly what I did for 24 years now, because you can identify, thanks to electrical mapping, the critical networks with the cortical hub and the white matter tract in the subcortical connectivity. It's reliable, it's online, and you can do so in real time anatomo-functional correlations by doing a real cognitive monitoring thanks to collaboration between patient and the neuropsychologist. So the most important is to select the good task for this patient at a time. Of course, the patient do not want to be aphasic hemiplegic, but I did not induce any permanent severe aphasia and hemiplegia for more than 10 years. And I cannot lie, because 90% of my patients are coming from abroad. So it's not enough nonetheless to be human being, because what they want is to continue to enjoy normal life, familially, socially, and professionally speaking. So we have to adapt the tasks according to their lifestyle. But we have also to take into consideration the environment. I receive patients from the 5 continents. And speaking about legal issues, if I induced hemianoptia because we decided with the patient that it was not mandatory to map the visual pathway, then in France, they cannot drive anymore. And I'm sure it's the same thing in US, but it's not the same thing in North Africa, for instance. They can drive. Cultural aspect. I cannot operate with this reliability patient coming from China speaking ideographic language, because I don't know enough the neural basis of ideographic language, while I know very well, I hope at least, the alphabetic languages, speaking about English, French, Spanish, even if I cannot speak by myself, but with a translator. It's possible to understand when to stop. Economical parameters. In France, the postoperative cognitive rehabilitation is reimbursed. It's not true in the vast majority of countries. And this is the reason why, to my opinion, patients are not recovering perfectly in comparison with some of our patients, because sometimes our priority on patients not able to be rehabilitated in other countries, and the recovery was not perfect. So you see that in fact, it's not just related to the lobar location of the tumor. We have to understand that if you remove a frontal tumor, an insular tumor, a temporal tumor, a parietal tumor, in all cases, in the end, you will be into the contact of the yellow fascicle here, the inferior fronto-occipital fascicle. So you have a risk in all cases to induce semantic disorders and for the patient not to completely recover. Of course, the patient will not be aphasic, hemiplegic, but the patient will not return to normal life. And we have to understand that before to go to the operating theater according to the needs of the patients. In other words, once you know the connectivity of this patient at that time, then you can do the resection, not of the tumor, but a part of the brain invaded by a chronic tumor disease according to the functional boundaries, both at cortical, subcortical level. So this is the reason why I don't need your navigation, DTI, fMRI, intraoperative MRI, microscope, ECOG, and so on. It's not because I'm against that. I'm doing that before and after surgery in order to do research, but because it's a limitation of your own mental imagery into the operating theater. And I will prove that by giving, of course, you my results at the end of the talk. So now, the simplistic view of neurosurgeons is to say, okay, we have understood, we have to awake the patient, but in the left dominant hemisphere, so-called dominant hemisphere for language mapping, but not in the right. You think that I don't need the right hemisphere when I'm doing this kind of talk, not in my native language in front of the screen, because I have no mentalizing anymore, because I'm not seeing the reaction of people in front of me, or when I'm doing surgery, for instance, next Monday, I need both hemispheres in order to build the brain. So if it's true for me, it's true for my patients. So it's true for your patients, because the right non-dominant hemisphere is critical for movement coordination. Is different not to be hemiplegic versus to play piano. Spatial cognition to avoid hemideglect, otherwise you cannot drive. Social cognition, otherwise you cannot communicate with other people. You have no empathy anymore. Non-verbal semantics, most of the time we are not speaking in the word, and we can understand the environing word based on our semantic processing with a high level of control. Executive working memory, able to do many things simultaneously. Personality, behavior, and so on and so on. And you will tell me, okay, we would like to preserve that, but it's not possible into the operating theater. Of course it is possible. We are doing that for more than 10 years, and we have the results with the scores before and after surgery, and the feedback provided by the patient and the family with many years. So if we can do that in Montpellier, you can do that. You will tell me, but you do not remove enough tumor. Of course, I'm removing more. This is the reason why my median survival is more than 16 to 17 years now. So the dilemma is solved. What is the secret? Stop to think that localizationism exists. There is no one area corresponding to Broca's area. You don't believe me? It's published in Brain. Neurologists accepted that many years ago because they cannot do differently, because they cannot say you lie, because they know that in fact the brain is much more complex. So now you have to add new tasks according to the quality of life defined by the patient himself. You are a mathematician, we have to include calculation. You are a dancer, we have to include spatial cognition, even in the right non-dominant so-called hemisphere, because I have not to decide for my patients. I am not them. You are a writer, we need to preserve syntax, and so on. But in all cases, we are human beings. And human being is, first of all, emotion, behavior. So we have to propose that in all patients. And they decide. But if they say, yes, I would like to preserve my empathy, you have to be able to propose, but also to preserve these neural networks involved in low and high level of mentalizing in order to say to the patient, I'm sure you will return to a normal life, including familiarly speaking with the same affect, the same personality. What is the secret? To know the connectome. In this example, of course, everyone understands that if we cut the premodal pathways, the patient will be hemiplegic. If you don't cut, they are not hemiplegic, so you can say my patients are well. No, they are not hemiplegic, that's it. But we published recently, past year in Brain, mapping of the networks involved in the control of movement. When you do a surgery by yourself, you need, of course, more complex movement and not just to avoid to be hemiplegic. And to do that, you recruit other networks which are in front and behind the so-called Rolandic system, with, of course, the connectivity and especially the involvement of what we call the frontostriatal tract. When you stimulate it, the patient will stop to move and or to speak. But it's not enough, because we need the somatosensory feedback in order to have a beautiful movement. And to do that, you have to wake the patient in order to identify the somatosensory area and thalamocortical pathways, but also the pathways involved in the awareness of your body. Otherwise, you are not perfectly connected to the environment. If the patient is telling you, I need to continue to have a very accurate movement and not just, I want to not be hemiplegic. Same thing for the hemianoptia, we have to avoid it if the patient disagrees to have hemianoptia because he cannot drive anymore. He can just decide for himself, and it's very easy during surgery to preserve the pathways. It's possible by using a line bisection task to avoid hemi-neglect. You can publish in Science, you can be very helpful for patients, and you can better understand the connectivity underlying this very complex network. So everything is related. Speaking about language, I'm sure that everyone now knows that there are two pathways, at least, dorsal pathway involved in phonological and articulatory processing, and what we have definitely to accept, because this is the truth, it's not just my view. It has been demonstrated using DTI, dissection, and so on by other teams. The so-called Broca's area, the pars opercularis of the left inferior frontal gyrus, is not directly connected to the posterior part of T1, namely the Wernicke's area. It's connected to the posterior part of T2 and T3. In the field of cognitive neuroscience, it's just an evidence, but not in the field of neurosurgery. How do you want to apply the brain if we don't know the anatomy? And your surgeons are telling most of the time, I know the anatomy. No, because the anatomy is much more complex. I don't know the anatomy. Speaking about the ventral semantic pathway now, the inferior fronto-occipital fascicle is so complex that when I started to say there is a pathway involved in semantic processing 15 years ago, many colleagues, anatomists, told me it's not true because this pathway does not exist in chimpanzee. But now we are telling, in fact, there are two pathways. And some colleagues are telling there are 5 pathways. So you see that we don't know the anatomy because it's much more complex, and explaining more and more why we have to be cognitive neuroscientists and neuroanatomists before to operate the brain just according to technology like neuronavigation, because never neuronavigation will give you this kind of very accurate functional information. For instance, now speaking about the inferior longitudinal fascicle. If you cut the anterior part, you will see an increase of reaction time during lexical access. You can tell me we can enjoy a normal life with that. Yes, but is it possible to accept that for this patient now? So you have just to ask the question, do you want to preserve the lexical access? Yes, no. And I will adapt the surgical resection according to your wishes. The posterior part is critical for reading. Is it absolutely crucial for you to avoid any degrees of alexia? What is exciting nonetheless, and this is the concept of networking brain and finally meta-networking brain. Speaking about the ILF and the uncinate fascicle. Despite the fact that you can have an increase of reaction time regarding lexical access, you are not totally aphasic. Because even if you cut this sub-pathway, you have a compensation by the direct pathway, which is the inferior fronto-occipital fascicle. And this is the reason why we can do a very extensive left temporal lobectomy in low grade, in high grade, in epilepsy, and so on, and to see patients still able to speak following surgery, because we start to understand that it's not one area compensating another area, but one subnetwork compensating another subnetwork. And you will see in the end that now we start to understand that a network is able to compensate another network by changing the strategy, the behavior. Speaking again about the inferior fronto-occipital fascicle, because definitely this is probably the most complex, the more complex pathways in a human being. It's also involved in non-verbal semantic processing. For instance, if you show gloves, like in this example, and you ask to the patient if gloves are related with hands or feet, you have understood, of course, that when you stimulate, if the patient is combining semantically gloves with feet, you induce a transitory problem. What is exciting is to understand that the right in the so-called non-dominant hemisphere, inferior fronto-occipital fascicle, is involved in this processing. So that means that if you cut the right eye off, and you will meet the patient in front of the family the day following surgery, you are telling to the patient, "How are you?" He's telling you, "Well, can you move?" "Yes." And you say, "You see, my patient is good, is nice." No, not at all. Because if you start to ask something much more complex, which is crucial to return to normal life, especially working full time, the patient will not be able anymore because he cannot understand complex information. And this is true also for behavior. We added many years ago a task into the OR, which is to recognize the emotion expressed by faces in front of you, and especially eyes. When we stimulated, sometimes patients were not able to recognize sadness, happiness, and so on. This is true, cortically speaking, but this is true, once again, at the level of the connectivity. And the other secret is that the right eye off is critical for mentalizing. So we cannot say, I will operate in the right so-called non-dominant hemisphere under general anesthesia using MEPs to avoid hemiplegia, and the patient will be well. No, you will avoid hemiplegia, but the patient will not be the same anymore. For instance, example, we have tried recently to model very, very easily. It's a simplistic view of the so-called right non-dominant hemisphere. Speaking about the connectivity, so speaking about mentalizing, non-verbal processing, bimanual coordination, and so on and so on. What we have seen, I will not redevelop. How do you want to map that under general anesthesia? How do you want to use the navigation of the DTI and to think that it will tell you, oh, be careful. If you continue to resect it, then the patient will have some problem of low level of mentalizing the theory of mind. You know, a tool able to give you this information online. So we have to stop to say technology is the solution. Technology is the limitation of the understanding of brain processing. How to demonstrate that? My results with cognitive scores in all cases following surgery and long-term follow-up. The goal, remember, was for the patient to live longer and better. So about my first 800 diffuse low-grade glioma operated on with more than 1,000 awake surgeries, because once again, 25 to 30% of my patients have been re-operated on because they're still alive and I did not cure them. But it was in the vast majority of cases, bias of recruitment referred to Montpellier because in the Broca's area, Wernicke's area, Rolandic area, and so on and so on. And for me, it was not a problem because I understood that localizationism does not exist. It does not mean that I am a better neurosurgeon. That means that I am not under the pressure of the dogma, which is totally wrong. The proof, mortality 0%. 0.5% of severe permanent deficits. I had 2 problems in 2 patients related to deep stroke when I was too close to the anterior perforating substance. Now I understood that I am protected thanks to the IFOF, even in the so-called right non-dominant hemisphere, by doing a wake mapping in the temporal stem, so protecting you from the anterior perforating substance because a little bit more superficial. But what is very exciting is that by removing Broca's area, Wernicke's area, extensively the frontal lobe and so on, thanks to a post-operative cognitive rehabilitation, and objectively demonstrated in comparison with a preoperative neuropsychological assessment, patients improved in 30% of cases, plus, of course, 80% of positive impact on epilepsy. And thanks to the low-grade glioma network in France, we demonstrated that epilepsy in low-grade glioma is not related to the core of the tumor, but to the peripheral invasion. So that means, in other words, that more you remove the tumor, of course, more the patient will live longer, as you will see. But more you remove the cortex around, according to functional boundaries, but using plasticity mechanisms, more you will control or avoid epilepsy. So more you will improve the quality of life. So there is no dilemma. The dilemma is just in the brain of neurosurgeons, not in the brain of patients. And if we can do that in San Francisco or in Montpellier, we demonstrated with Mitch Berger many years ago, thanks to this meta-analysis, that everyone can do that thanks to intraoperative mapping. So the problem is solved. If you do not perform intraoperative brain mapping in your hospital, you have a problem. We have to better understand mechanisms of neuroplasticity. And to do that, functional imaging, because non-invasive, is absolutely beautiful. This is the reason why I love it, but not into the OR. So I took the habit 20 years ago to do pre and post-operative fMRI and to see how the patients were able to recover, like in this example, after a supplementary motor area syndrome. And the answer, as you can see, is this is the network with the recruitment of the contralateral homologous area, the SMA, the premotor cortex, but also with an activation here of the ipsilegional precentral, retrocentral, parietal, what we have seen. So it's a bilateral network. What means non-dominant hemisphere? Why is it so important to understand that? Because we cannot cure definitely patients with low-grade glioma, but we can reoperate. How is it possible to remove more brain than more tumor? Many years later, because in the meantime, mechanisms of neuroplasticity occurred and especially pushed thanks to post-operative cognitive rehabilitation. So I started 5 years, 10 years later to reoperate and to demonstrate that the map changed in the same patient over time, and then to remove more tumor while preserving the quality of life. This is true in the central area, knob of the hand, but this is true also for language. And very recently, because more or less there is nothing about that in the literature, we published 6 months ago a paper with fMRI before and after surgery, as you can see, speaking about language in patients who recovered. And you can see that it's a problem of reconnectivity using the interhemispheric connectome. I mean, you need both hemispheres in order to compensate this kind of lobectomy, but this kind of unsolved tumor. Remember, if you do a preoperative cognitive assessment, in the vast majority of cases, the patients are not perfect. So we have to understand that. The modeling of the brain before surgery, after surgery, before second surgery, after second surgery, and finally now I'm doing more and more third surgery. Example, Wernicke's area. I was not able to remove during the first surgery. I did not push. I don't want to induce any aphasia, of course, but I hate to lose. So I came back 10 years later. And at that time, as you can see, by preserving the connectivity in the depth, the ILF, the arcuate, the I4, blah, blah, then I was able to remove completely the left temporal lobe because in the meantime, remapping occurred. This is true in Broca's area. I was not able to remove the pars opercularis of the left inferior frontal gyrus in this patient at that time. I say, okay, what I want is first of all to give him the opportunity to live longer, but also better. But I will come back. It's exactly what I did 10 years later. It's possible to do that very aggressively, speaking about the imaging, because these patients enjoy a perfect normal life, including this patient with a bilateral frontal lobectomy, driving, taking care of his children, working full time, and so on. And with cognitive scores, of course, demonstrating that the patient is well, but because we induce this plasticity over years. You will tell me you are doing so many tasks into the war, you are a scientist, but The goal initially was for the patient to live longer. I understood. This is the reason why my patients are living more than 16 years in a prospective series. So remember, with a biopsy, it was 6 years. So we added 10 years with a normal quality of life. It's not the end, because 25% of my patients are still alive 20 years following the first surgery. I need to become older. What was another secret? To understand definitely that it's a diffuse glioma and that the flare is not the disease. So if you can remove more than the flare, as done everywhere in the organism in oncology, so you will increase the chance to control the tumor better. So it's the concept of supratotal resection. The goal is not to remove what you can see. The goal is to remove more, and you will tell me where to stop according to functional boundaries. What functional boundaries? What we have seen, the supramodal semantic processing, bimanual complex coordination, language, semantic phonology, articulatory syntax, mentalizing, low level, high level, dual task, and so on and so on. What will happen? No malignant transformation in comparison with my group of total resection when I took a margin. No radiotherapy. So of course, no death, normal life, because I arrived earlier most of the time. Remember, and it's exactly what we will see, to arrive earlier and earlier in the natural history of the disease. Stop, wait and see. The secret for that is to do preventive neurosurgery. And this is the reason why I started to operate more and more incidental discovered low-grade glioma in the past 10 years. Indeed, if you do a preoperative cognitive assessment, you will tell me, oh, it's just incidental discovery, so the patient is well. No, in 60% of cases, they're not well. We have to be objective. So we have to do systematically preoperative cognitive assessment before to say the patient is well. You will tell me, but you operate just for fun because in fact nothing will happen in incidental low-grade glioma. Really? You see this case, for instance, and unfortunately I have seen too many cases like this. Suddenly, because the patient was followed in another institution, the patient remained asymptomatic, but the tumor became a glioblastoma. And the patient was referred to me 4 years later. It was a glioblastoma. Of course, I did surgery, but the patient died 3 years later. I can tell you that I would have been able to do a supratotal resection if the patient was referred to me since the beginning. And then I can tell you that the patient would have been still alive today without chemoradiotherapy. I'm sure about that because it's true for 100% of patients that I did supratotal resection. But surgeons and neurologists decided that it was too dangerous to do the resection of the right insula initially. Finally, we killed the patient. I did more than 100 patients with low-grade glioma. What happened when we did low-grade glioma with incidental discovery? The tumor were smaller. I did 30% of complete resection plus 30% of supratotal resection plus no partial resection. So I changed radically natural history of this disease in these patients. Nonetheless, 30% of them had already some foci of malignant transformation. This is not a benign tumor. But none of them kept any permanent deficit. Why? Because no seizures. Remember the third slide. So that means, in my talk, that the brain plasticity limitation was not reached. So that means that you can push the resection and the patient will be able to compensate because brain plasticity will be optimal thanks to postoperative cognitive rehabilitation. And we demonstrated that just by publishing this year in neurosurgery. Now, the return to work. 97% of patients resumed their employment. And not just, they are not hemiplegic aphasic. They are enjoying perfect normal life. With, you can see, so 95% of patients still alive with 6 years of follow-up in this subseries. So I proposed in front of the National Academy of Medicine 3 years ago to do a screening in the general population. And they said yes, because 66% of possible patients would accept to benefit from a screening thanks to a non-invasive MRI in order, of course, to be operated on earlier. And why we can do that? Because we know the limitation of neuroplasticity. You are telling me how to know that? Because we published the atlas, probabilist atlas, of course, of brain plasticity in the MRI template already 4 years ago in brain. And no one is using this atlas because I don't know, because it's just an evidence that we have to understand where to stop into the operating theater according to the knowledge of the connectome. But if it's true for neurosurgeon, it should be true for medical neuro-oncologists. And unfortunately, medical neuro-oncologists don't know the functional anatomy of the brain. So that means that if you have an invasion of the contralateral hemisphere, the contralateral connectivity, you cannot reoperate. You can, but you will cut both pathways and you will induce permanent deficit. In this case, please do chemotherapy. No radiotherapy. I will tell you why. If you do chemotherapy, you will induce a shrinkage. You will tell me, yes, because the molecular pattern. No. In this case, for instance, it was a 1p19q non-codilated tumor, and we did that in hundreds of tumors. Example, partial resection, temozolomide, shrinkage, second resection, 10 seizures a day before surgery, no normal life, no seizures anymore, driving and working after this kind of strategy, independently of the molecular biology. If you do radiotherapy, what will arrive? It's not my view. It has been published objectively thanks to evidence-based medicine. Early radiotherapy, no impact on the median survival in comparison with delayed radiotherapy, but decline of cognitive function. And you know why? Because irradiation in essence of the connectivity. And once again, we don't know the connectivity. So we are telling we improve the methodology, the technology of radiotherapy, like for us, the navigation intraoperative MRI. But once again, the technology will not provide this kind of functional information. So if we are not neuroscientists, we cannot deal with the brain. It's true for neurosurgeon, but it's true also for radiotherapists. And when they start finally to be objective and to do pre and post-operative pre and post radiotherapy, DTI and cognitive assessment, they said after 1 year, we started to have problem. Of course, this is the reason why in the RTC, so it's not me, Monica Egi proposed recently, regardless of the 1p19q status, I changed nothing, to defer radiotherapy for preservation of cognitive function and quality of life. You have the feeling that I wrote that, but it was 20 years later. And finally, we start to say, maybe be careful, radiotherapy could induce some deficit. Yes, because we are not speaking about glioblastoma with median survival 2 to 3 years. We are speaking about patients living 20 years. So we propose to change radically the management of this patient thanks to a recursive strategy. First of all, do not follow them, operate. Second, according to functional boundaries, then induce plasticity thanks to post-operative cognitive rehabilitation and return to a normal life, which is the best rehabilitation. Then come back by doing surgery again. Then come back if you cannot give chemotherapy, which will not induce this kind of permanent severe deficit regarding the cognitive function in comparison with radiotherapy, independently of the molecular pattern. And finally, now I start really to irradiate more and more my patients after 10 to 15 years. Median survival, once again, more than 16 years. So it's not against the overall survival. And we started, it's politically incorrect, to avoid to do too early chemotherapy and radiotherapy, even in low-grade glioma, with foci of malignant transformation, including foci with grade 3 and grade 4. We published that in Neurology this year, just 3 months ago. You can see 5-year survival, 95%. I cannot lie, but because I did a very extensive resection. An example, you see that it's real enhancement. I did the surgery in 22. I did extensive resection, the patient enjoyed on my life. It was, of course, in the middle of grade 3. I did no chemo, no radiotherapy. It seems that I am probably crazy, but nonetheless, 3 years ago, I did for the second time surgery, 15 years after the first surgery. And what happened? The lab told me it's a low-grade glioma now. Oh, really? Maybe because I removed the focus of malignant transformation initially. And the patient is not irradiated today. No chemotherapy. We have 18 years of follow-up. And it's not just one case. I have hundreds of cases like this. But it could be, of course, dangerous to push the resection according to functional boundaries. No, because we have to be scientists to operate the brain and to use this knowledge in order to elaborate new models of the brain, and you can publish by yourself as a surgeon in Nature. And if you have this kind of connectome in your mental imagery, so more than the information provided by technology, then suddenly you can operate with 99% of reliability. And to help younger neurosurgeons, we published just this year the sole atlas in the world literature with the critical networks, speaking about the cortical hub and the white matter tract. DTI is not a function. We published the function in 16 functional domains. And now everyone can use it. And to conclude, so what we did is now to model the left, the right hemisphere, and to develop the concept of meta-networks. What means? That means that when you have one network involved in language, for instance, it's constituted by different subnetworks, as we have seen, dorsal pathway, ventral pathway, syntax, prosodia, and so on. But we don't need only language in order to enjoy normal life. And we have to create sometimes interactions between different networks in order to solve this problem. I mean, to be adapted, speaking about the behavior, because suddenly I have a warning, for instance, in my house. And then warning alarm means that it's not language, but means probably it's fire. But maybe it's not just fire, it's maybe just a problem of the alarm. So I have to check, but I have also to find the good behavior against my emotion, because suddenly maybe my house will burn, and so on and so on. So you create interaction at that time to solve this behavioral problem between different networks, and you will permanently keep this new meta-network. For instance, in my house burned, because I will remember that all my life, or it will be just transitory because the alarm had a problem and finally I will forget it this evening. If we have to do that, the patients should continue to do that. And you will tell me what is the relationships with the intra-party mapping. Is that if you think when you stimulate, if you are doing wave mapping, you induce a transitory deficit, and the deficit is related to the location you put the probe on, and this is the area corresponding to the function, you can stop. Because in fact, what you are doing when you induce a transitory deficit is a disruption within a complex network. And this is the reason why it's absolutely critical to ask the patient to do at least 2 tasks simultaneously. For instance, to move and to do a semantic association or mentalizing task every 4 seconds. Because sometimes you have a patient, when you stimulate, still able to move, still able to speak, but not able to do both simultaneously. And you disrupted at this moment the meta network. And you will say, I don't care. What I want is to just avoid hemiplegia, aphasia. Okay, you don't care. But once again, what about the patient himself? Maybe he would like to be able to continue to do a multitasking 3 months following surgery. So to conclude, talk to the brain, forget the glioma. We have to learn very, very accurately the glioma before surgery, do the volumetric assessment, calculate the kinetics, of course, following surgery, benefit also from the molecular biology. It's just a part of the history, but a critical part. And then you will build a big equation, but into the operating theater, you should see the brain. If you use technology, that means that you are lost in the brain. If you are lost in the brain, that means that for younger people, you will become addicted And without near navigation, without intraoperative MRI, without DTI, without fMRI, without blah, blah, you cannot operate. That means that you have a problem, because normally you should know where you are. And to stimulate in awake patient, it's just the validation, the confirmation of your mental imagery. And this is the reason why you can achieve this kind of resection by giving more than 10 years to your patients of normal life, thanks to your knowledge of the connectivity. But you have to adapt your strategy according to the wishes of the patient in agreement with the Hippocratic Oath, not in agreement with the evidence-based medicine. We have to know the results in the literature, but we have now to be plastic in front of this patient at that time. So you have the choice to treat a human being or to remove a tumor. Good luck.
Well, thanks a lot, Dr. Hughes Duffau. It's really superb. I'm speechless. Excellent. It was an excellent presentation. Thanks a lot. And we are going to start a round of questions. Is there any question from our expert panel? Dr. Servio.
Sí, Professor Duffau, many other colleagues are saying that maybe in subcortical stimulation, monopolar stimulation is better than bipolar stimulation. What is your opinion about that?
I never used in my life monopolar. I use systematically bipolar. So that means that technical issues, I don't care. Because once again, I do not use stimulation because I don't know where I am into the brain. I use stimulation in order just to validate where I think I am. And because I have visitors, as you know, for more than 20 years for each my surgery, except in this period, of course, they can see that when I take the stimulator, the probe, for the first subcortical stimulation, I will induce in 95% cases a disruption during my first stimulation. It was just a validation. According to that, bipolar, monopolar, 60 hertz, 12.5, 2 milliamps, 5 milliamps, and so on. You don't care. I induced a positive mapping in 99% of my patients in front of witness. So use low intensity in order to avoid epilepsy. Never I had to abort one awake surgery, about more than 1,000, as you have understood, related to epilepsy. The next meeting I will go, I will hear, I'm sure, I have 15 to 20% of epilepsy, awake surgery is dangerous, patient is not collaborative, blah, blah. No, it's because we use too many stimulation, because we increase the intensity, because we are lost in the brain. You need sometimes just to stimulate by telling, okay, it was the IFOF, put a tag. Okay, it was the arcuate, put a tag. Okay, it was the somatosensory pathway, put a tag. And in fine, you stop your resection in the stratum sagittale.
Do we have another question from the panel? Dr. Recalde?
Yes, thank you for a superb lecture, Dr. Duffau, always introducing us into new concepts. I may have two questions, if I may. One may be related to how do you think is the best way to map the visual pathway? And the other one, as you said, right now we are not more used to reoperations on our patients. So usually we have a bit of attachments of the cortex with the dura. Do you have any tip to avoid that on reoperations? I know some surgeons sometimes use some kind of synthetic materials to avoid that addition. That would be.
No, to reoperate, and especially to reoperate, and sometimes with finally radiotherapy in between. My secret is just that I love to suffer, and that's it. So I need 1 hour to reoperate without any coagulation to reopen. And of course, the patient is under general anesthesia at that time. This is the reason why I hate awake, 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 but asleep, awake, asleep, because I have the time to avoid any coagulation, to save my time and to spend 1 hour or even 1 hour and a half in order, in fine, to have a beautiful exposure and to avoid any vascular problem. I have no trick, I'm sorry about that. But speaking about the visual pathway, initially, it was a little bit too subjective 20 years ago. When you stimulated, patient can have phosphines or blurred vision and so on. So we decided to try to be more objective. And for more than 10 years, we decided to ask for the patient to give names or to read or what you want at the level of the same screen, 2 different quadrants. And then the patient, of course, have to fix a red cross in the middle of the screen to avoid saccades. And then it's very frequent when you stimulate that the patient is telling you not a bed in a car, but just now a dog. So that means that patient was not able to see the cat. It was not a language problem because the patient gave the good name, but had transitorily an amputation of visual field. And at that time, then we decided, of course, before surgery to accept or not. And in the example I gave, it's a upper quadrantanopia. And most of the time, the patients are telling, I don't care if you can remove more because you can drive despite an amputation of the upper quadrant. But if it's a lower quadrantanopia, then you can be really disturbed in your quality of life. So you see, we can be very, very accurate, but once again, thanks to the fact that I have very good speech therapists and neuropsychologists into my OR, because in fact, at that time, they give you the translation, if I can say, of the neuropsychological assessment. And that's true for the mentalizing, the verbal, non-verbal, semantic processing, and so on. In other words, all people in my operating theater are PhD in cognitive neuroscience. The speech therapist, the neuropsychologist, the neurosurgeon, the neuroradiologist who did the preoperative fMRI, because we can speak nonetheless about mechanisms of neuroplasticity before to go to the OR, and so on and so on. And I think that this is the secret, really. If we can understand the brain with a higher level of reliability, knowing that it's unless, of course, then we increase really the reliability into the OR. But we have to continue to better understand this functional anatomy.
Thank you.
Okay, thanks, Dr. Recalde. Do we have another questions from the panel? Perfect, yes. Go ahead.
Hello, doctor. Thank you for your talk. I have a question about the low gliomas, low degree gliomas in the right side. What is your advice about that? Because sometimes for us it's very common and simple, the planification of the surgery in the right side, no awake, is in the sleep surgery. But maybe we can change this point of view and to do this surgery in awake surgery, because sometimes one anatomical resection when the patient is asleep is no total resection. What is your point of view, or what is your advice for us about that?
Each time I had the opportunity, if I can say, because it's too frequent to my opinion, to reoperate a patient operated on in another institution under general anesthesia in the right non-dominant hemisphere. In 100% cases, I did a more complete resection under awake mapping. And in the vast majority of cases, I did a supratotal resection. And you have seen the results with more than 10 years of follow-up, the rate of death in this subgroup is 0. So that means that when you do a beautiful resection under general anesthesia in the right hemisphere, in a so-called non-critical area like the prefrontal lobe, beyond the fact that probably you have induced some cognitive or behavioral disorders and you're not aware about that if you don't you do not perform an objective cognitive assessment. I don't speak the day after surgery. I mean 1 year, 5 years, 10 years later. Beyond this fact, in the vast majority of cases, it would have been possible to remove more and then to change radically the natural history of the disease. And if you would like just to be convinced about that, I can propose you to ask to your patients the last 5 years with no chemo, no radiotherapy in order to avoid any bias, to come back and to have a cognitive assessment. And you will be so surprised about how finally they are not normal. And on the other hand, but so frequently they regrew. And finally, I have to reoperate now. And at that time, please do the second surgery in the same patient, the second time under awake mapping. And you will see that thanks to a postoperative cognitive rehabilitation, it will recover better objectively, and you will remove more. And now you will be convinced.
Thank you very much.
Do we have another questions from the panel? So, okay, we have some questions from our viewers. Dr. Cremaschi asked Professor Duffau, do you have experience operating on Japanese patients?
No, because as I told you, I know my limitation of the knowledge of functional anatomy. This is the reason why I told you I don't know the functional anatomy enough. So if you speak ideographic language, I am the first to say some patient who came from China or Japan, I'm not the good one, because your brain is not like my brain, speaking about alphabetic language. So what I did is to train younger people, now they are not so young, in China, in Japan, and so on. And then I can refer very honestly, I hope, the patient to these neurosurgeons in this team with cognitive assessment in their native language and knowing the neural basis of Spanish, Japanese or Chinese. And then they will do a better job than me because at that time, I am not a good neuroanatomist.
Perfect, thanks. We have another question from our viewers. Is knowing that early preventive surgery in low-grade gliomas is mandatory, what is your approach to pediatric patient in which you can perform awake surgery?
I'm not a pediatric neurosurgeon, so that means that it's very difficult for me to answer this question. But I can tell you, first of all, that most of the time in a pediatric population, diffuse glioma is really exceptional. I do not speak about the brainstem. So that means that you have a ganglioma, pylocytic, so the problem is not exactly the same. But nonetheless, I did sometimes surgery recently in patients around 13-year-old. And if you prepare the patient with, of course, your team of neuropsychology before surgery, it was not a problem during surgery. And then it has been possible at that time to remove more than expected by the surgeons in the country of this patient, despite a translator into the OR at 13-year-old. So that means that it's really a good indication and the motivation of the patient thanks to a good team around the patient. In other words, the surgeon is of course critical, but just a hub in the network, and you need to build really a circuit, a meta network around the patient, especially in younger one. Otherwise, just the surgeon, despite a very big experience, will not be so reliable by himself alone.
Perfect. Perfect. We have another question of our viewers. It's how to apply those concepts of language and supratotal removal when you have a patient already presenting preoperative language deficit.
It depends on the mechanism. I mean, I did many surgeries in patients with not complete aphasia, but already language deficit before surgery, and especially related in these cases to high-grade gliomas. But because related to my knowledge of the functional anatomy and the atlas of neuroplasticity we published, and I have more or less in my brain, it's normal, I do that for more than 20 years, I am able before surgery to know if the deficit is related to a compression mass effect on the pathways or an invasion and destruction of the pathway. If it's a high-grade glioma with already an invasion by the enhancement of the junction, for instance, of the IFOF and the arcuate in the posterior T2, then you can operate if you want, but never the patient will recover. So you can say before surgery to the patient, and especially his family, be careful, I can operate you, I can remove the enhancement, but you will continue to have permanent aphasia. So it's a philosophical issue. If I know that it's a mass effect, I will go to the OR, if the patient agrees, of course, and then I will do the first part of the surgery by debulking more classically in the middle of the tumor under general anesthesia. Then I will ask for the anesthesiologist to awake the patient in a third step after the opening and after the debulking. And at that time, very frequently, if your preoperative analysis was good, then you will see the patient improving online thanks to a decrease of the mass effect. And that means that you can do, in the end, exactly what I proposed initially, because you changed not only the natural history of the tumor by pushing the resection in the end, but you improved the quality of life thanks to the fact that you debulk initially. Sometimes, the last strategy, the tumor was really too big with a very big mass effect. The patient was almost aphasic. Then I did surgery because under general anesthesia, of course, the family told me, you have to operate, please give a chance. And finally, the patient improved. And then I came back, even in high-grade glioma, in order to do a supratotal resection, speaking about 50% of the flare, so more than the enhancement, while the patient recovered in the meantime. So you see that, in fact, we have really to think about a dynamic, multiple surgical approach, and not to think that it's just now, today, and that's it.
Perfect. We have another question. How do you decide when to reoperate after a subtotal resection due to deficit during the first resection?
This is a very, very good question because, of course, the answer is it depends on the patient, on so many parameters. First of all, the natural history of the disease. If the tumor is growing a little bit too fast, that means that surgery per se will not be so efficient. And in these cases, you have probably to give chemotherapy earlier. I don't speak about radiotherapy, you understood why. But on the other hand, because the brain plastic potential will not be so efficient if the brain has to deal with a rapidly evolving lesion. If the tumor is growing very slowly, then the brain plasticity will be more efficient. But it will depend on this case. If the tumor is growing in particular and mainly at the level of the cortex, because the cortex is much more plastic, then you have a chance to come back. Or if the tumor is migrating along the white matter tract, and then you will not be able to come back and to be efficient. But you have to deal also with the functional issues. In other words, what about the recovery after surgery according to the postoperative cognitive assessment 3 months after surgery and after the rehabilitation? Second, what about still seizures or not? Because I continue to have 5 to 10% of patients with seizures. And in this case, of course, they have anti-epileptic drugs. And in this case, the plastic phenomenon are not exactly so efficient. What about the needs of the patient? Sometimes he's telling me, okay, I recover now, I would like to be reoperated on because my goal is really to tend toward a supratotalization because I would like to have all chances to live longer. Or sometimes patient, no, I needed 2 to 3 months to recover following the first surgery. Now I want to enjoy a normal life. and we will continue to calculate the growth rate. And if the tumor is growing slowly, then you will reoperate me in a few years. And by combining everything, if you have a slow-growing tumor, not so migratory pattern, in a patient enjoying normal life, and with no symptoms, especially no seizures, after many years, I will finally make the decision with the patient because the volume of the tumor. And it was, you remember the fourth slide of this talk, the volume is related to the risk of malignant transformation. So beyond 10 to 15 cc, because it has been demonstrated in US by Mitch initially, reproduced in French, it has been confirmed recently 3 years ago in Germany and so on. The risk to see malignant transformation is higher. So you see that in fact, we have a big equation to solve for each patient. But to give you approximately my mean time before reoperation is between 4 to 5 years.
Perfect. We have more questions, Dr. Duffau. One of these questions is for incidentally asymptomatic discover. Do you put the patient in a training program with a specialist to generate plasticity before surgery? Could improve that surgery when surgery will be necessary?
It's a good question, but I don't know, because from now, we started to do surgery in asymptomatic patients. And of course, you have understood that in 60% cases, they had nonetheless some mild but objective cognitive deficit. And we did the rehabilitation after surgery and it worked. But you're right, in some cases, I did not perform supratotal resection. Remember, 30% of supratotal, 30% of complete. So nonetheless, 1/3 with just a subtotal removal. And it's a very good question because we started to think a posteriori that maybe it would have been a good idea to do a preoperative cognitive rehabilitation in order to induce plasticity and finally to avoid to come back and to do the complete resection thanks to 2 surgeries. But the problem is now, I revert the question, why we will a little bit reluctant. Because we needed, first of all, to better understand mechanisms underlying neuroplasticity at the individual level. And finally, as I said, so few papers giving you the opportunity to see functional connectome before and after surgery. And now, because we are publishing more and more this kind of papers, we start really to predict how the brain will reorganize at the individual level. So I think that we will be ready in, I hope, short term now to do this kind of new protocol before the first surgery.
Perfect. We have another question from another viewer. Dr. Duffau, you say most of the LGG you operate do not receive adjuvant chemo. In what cases will you recommend post-operative treatment?
I would recommend to postpone treatment.
Post-operative treatment.
Oh, once again, only if I was not able to do a subtotal resection. So if I left more than 15 cc, because most of the time it's related to the fact that there is an invasion of the deep connectivity, so the limitation of neuroplasticity, I know that I will not be able to come back at least before a few years. So there is a risk to see in the meantime the tumor growing too much. Second, because of a growth rate which was a little bit too rapid before surgery. And then I know that finally the natural story is like a high-grade glioma and not like a low-grade glioma. And most of the time, I can predict the results of the lab, but sometimes we can have discrepancies. So it could be a low-grade glioma according to the neuropathological and molecular assessment, but finally growing too fast. And if you combine both, growing too fast, the patient was not perfect before surgery and is not perfect after surgery, due to an invasion of the white matter tract connectivity with a residue more than 15 cc, I will be the first to say after 3 to 6 months, of course, in order to recalculate the growth rate following surgery and to give the opportunity for the patient to return to a normal life, but to say, okay, now it seems reasonable to avoid to wait and to administrate chemotherapy earlier.
Another question, is any situation in LGG that you consider not necessary at all the mapping of the brain?
Only if there is an absolute contraindication of awake mapping. I mean, maybe in the pediatric population, as I told you, I'm not the guy to answer this question, but I can leave this door open and sometimes to have an authentic low-grade glioma in a patient less than 10-year-old, a patient with so many previous medical history of disease and with obesity, but I mean really morbid obesity, and then anesthesiologists, despite their experience in my hospital, will tell me really we take a very big risk. Or patients with a psychiatric disease are telling you, I don't want to be operated on under awake mapping. So in this case, maybe, of course, we can do classically, but really in my experience, you can believe or not, but it's less than 0.5% of my patients. Maybe nonetheless, I have a bias of recruitment. I have to be honest, because they are coming from abroad in 90% cases. So that means that in the vast majority of cases, it's not a coincidence because they did surgery, they did seizures by living in Montpellier. They came to be operated on, at least to discuss about awake surgery, and in order to preserve their quality of life according to this philosophy well known. And then we can, of course, discuss, but in this a priori. So maybe this is the bias explaining why my patients are so motivated.
Perfect. One question. In the supratotal resection, which do you consider is the adequate resection margin?
Functional boundaries, the meta-networking. When the patient will tell me I'm not able to understand what means this diagram, when I cannot recognize the expression of the face in front of me, when I cannot do two things simultaneously, when I cannot give you the answer in 4 seconds, and so on and so on. So everything was pre-planned with the patient before, and of course with the neuropsychologist, in order to preserve a real normal quality of life, speaking about the behavior and the cognition, but not before. So once again, if I can take 2 centimeters of margin away from the flare, I will do that. And in these cases, to be honest also, I have some patients with more than 10 years of follow-up with no recurrence. Maybe finally I cured them.
Yeah, someone of the panel wants to make, I have more questions, but before I want to know, someone of the panel have any question? Dr. Recalde?
I have a short question, but I
Sure.
think I know the response of Professor Duffau.
Okay, do the question.
First of all, thank you very much, Professor Duffau. You are not a neurosurgeon, you are a neuroscientist, and you are a guide for a lot of people in the world. We visit him in Montpellier, and he is our inspiration. Really, he is a very good surgeon, but most important, a very good person. I think my question, I know the response, but in your experience, the survival rate of low-grade gliomas without contrast enhancing or with contrast enhancing is the same?
It depends on the extent of resection. In this paper we published recently in Neurology, we say that we could avoid to give adjuvant treatment with the same survival if I did at least a complete resection, speaking about the flare and not just speaking about the enhancement. Second, it depends also on the spatial organization of the tumor, because as we know, in fact, gliomas, I will not speak about just low-grade glioma now with enhancements, are very heterogeneous. And as you know, I have the habit to remove a big part of the brain and sometimes to refer the lobe directly to the neuropathological lab. And then my neuropathologist, of course, with a big experience because many tumors every week, will not only tell you the enhancement was a grade 3 or grade 4, but if around the enhancement, it was really a low-grade glioma, and in this case, the survival will be also prolonged and maybe without any adjuvant treatment, especially if we did a complete or a supratotal resection. Or finally, microscopically, you had foci of magnetization everywhere beyond what we can see also on the macroscopy on the enhanced MRI. And in this case, of course, I will be the first to propose post-operative adjuvant treatment, but in these cases, of course, the prognosis is not exactly the same.
Okay, thank you very much, Professor.
Thank you, Dr. Martinez. Another question, Professor Duffau. Patients you work on, you did surgery on, and that they have an early recurrence, less than 3 months. Do you do surgery again on them?
No, because that means that it's a glioblastoma in 3 months. So maybe I could come back in order to benefit from a second sample by telling something happened. After asking to my neuropathologist, we missed something, maybe it could not be a low-grade glioma. But in the vast majority of cases, if the tumor is growing so fast, my neuropathologist will tell me, be careful. So if I knew that, that means that surgery per se will not change radically the natural history of the disease. And in this case, I will be the first to ask to do not only chemotherapy, but also radiotherapy, because the natural history is the natural history of glioblastoma.
Dr. Recalde, you want to do another question? I have more questions, but do you want?
I guess Dr. Prost wanted to ask something.
Pardon me?
Dr. Prost, I guess.
Question.
Dr. Prost?
Yes. And thank you for your lecture, Professor Duffau. My question is, you make your point about the adjuvant treatment. My question is, if you consider, is there any room for a perioperative treatment before the surgery to convert maybe an inoperable lesion to an operable lesion?
Yes, it happened sometimes, what we call the neoadjuvant chemotherapy in this so-called gliomatosis-like, because you know better than me that it does not exist anymore according to the new WHO classification, but in the real clinical practice, unfortunately, it happens. And as I said, you cannot remove completely, of course, the hemisphere. There are some limitations of the plasticity, or sometimes you can have a butterfly, a low-grade glioma, and the patient enjoy a real normal life. So in these cases, when I know that I will leave too much invasion of the connectivity, I would prefer to do just a biopsy and to ask to my oncologist to do chemotherapy first, because in more than 50% of cases, you can induce a shrinkage of the tumor. And most of the time, of course, it's not just like a resection within the superficial cortical area, but when you induce a shrinkage thanks to the chemotherapy, it's a disinvasion, if I can say, of the white matter tract. And then the surgery could become possible thanks to you, exactly the case I have shown with the patient doing 10 seizures a day with a very wide invasion of the central area and the pyramidal pathways, the corona radiata. And finally, the chemotherapy allowed me not to do a supratotal resection, but at least a subtotal resection, and to improve the quality of life of the patient. So yes, I am very plastic. And this is the reason why we are discussing a lot, not only in my hospital, but also in the network we have in France, in Europe, and so on, with oncologists. In other words, our protocol is that we have no protocol.
Thank you.
¿Algún panelista, someone of the panelists want to make another question to Professor Duffau?
Yes, last time we were in San Francisco, I remember you told us that you were working on pregnant women with have been operated on low gliomas, and you were searching about the incidence of pregnancy on the rate of recurrence on these patients. I don't know if you have something published yet, or you have some information you can give us.
Yes, so the paper is ready. And to be totally honest, I'm waiting for 3 more months in order to reach, using the statistics, Clapham-Meyer curves and so on, enough follow-up in order to reach 0.05. And then finally, to answer your question, but because you were so kind to invite me today, I will give you something totally unknown and never published in the literature. If you do a complete resection of the tumor, low-grade glioma, even with some foci of malignization in the middle, but we are not speaking about glioblastoma and so on. And if the patient is pregnant, then you increased very significantly, at least in 3 months, the chance to avoid a modification of the natural history, and especially a malignization of the tumor during and just after pregnancy. And I can say that now because I will have enough follow-up to show the median survival more than 5 years after the pregnancy. And if you did not achieve a complete resection according to the flare, then it will be a predictive factor regarding the survival of the patient 5 years after pregnancy. So for the first time, we started to identify something to help patients to make a decision, and something we can change, and not just speaking about the molecular pattern of the tumor.
Thank you.
I want to make you one question. It's a very typical question, Dr. Duffau. You know that in plenty of countries around the world, there is a lack of access to molecular biology. So under that situation, do you change the strategy of the surgery since we have this lack of access, no?
Of course, no. Because in my network, I have big neuro-oncologists well known in the world, not speaking from Montpellier or France. And they are the first to say, whatever the intrinsic prognostic of the tumor, glioblastoma, grade 3, grade 2, with foci of malignant transformation, a real grade 2. And whatever the molecular pattern, if you do a complete resection, you will change radically the natural history of the disease. It's not me, it's neuro-oncologists who now are totally convinced about the fact that if you can remove the tumor, it's better. So why to do a biopsy? Just to say in fine, I will remove the tumor if you knew since the beginning that it was possible to remove completely the flare. Please do that since the beginning, and you will see what will happen.
Perfect. Perfect. Do we have some more questions from the panel?
Just to finish to answer this question, I would like to insist on the fact that it's not just my point of view. I do not understand the incoherency of some surgeons telling, according to the molecular biology in low-grade glioma, I will operate or not finally the tumor. But they are the first to operate glioblastoma with butterfly pattern. So I am the first to ask the question, are you sure that you are really helpful by giving the opportunity for the patient to live 2 months more, while I changed, sometimes with more than 10 years, patients with, as we have seen, focus of high-grade glioma or wild type. So we have to be full of common sense for younger people looking at this video, first of all, be logical with yourself.
Perfect. Dr. Nunez?
Yes, doctor, a simple question about the transopercular approach. What is your tips to help us about the correct point to entry? And for me, sometimes it's very common to lose the right direction when you do the resection of the low degree gliomas in the insula. What is your tips about this in the right direction to make a safety surgery?
For the transopercular approach, you need two things. First of all, to wake the patient in order to know what you can remove of in the vast majority of cases, the inferior frontal gyrus, because you will have a good surgical axis to be into the insula, including in the posterior part, even if everyone knows that the posterior superior part is complex in San Francisco, in Montpellier, everywhere. But speaking about the inferior part, the inferior posterior part, and a fortiori the superior part, you can remove it through the inferior frontal gyrus. So please awake the patient, whatever the hemisphere, because sometimes you can change the personality of the patient by removing the pars triangularis or opercularis in the right so-called non-dominant hemisphere. And then you will have a beautiful map. You will remove accordingly the operculum according to the second point, subpial dissection. So you will do the resection into the contact of the Sylvian fissure. And never, I will open the Sylvian fissure, explaining why never I had any vascular problem, at least related to the Sylvian vessels itself. I say that sometimes it happened in the depth at the level of the anterior perforating substance, but this is another topic. This is in the end where to stop and not how to reach it. So thanks to a subpial dissection into the contact of the Sylvian fissure, you will be finally on the surface of the insular cortex. So you will expose, at least in my experience, according to the cortical mapping, and this is the reason why it's very important to know if you can remove a little bit more, you will expose the circular sulcus of the insula. This is the point. Because at that time, you can take in what you want, in the pins, Debaki, and so on, the pia mater, and then to lift up the circular sulcus, and then you will be within the insula with never any contact with the vessels. And that means that you will now remove the insula subpially also from inside. And that means that never you will induce any spasm. Never I used papaverine in 20 years. And you will have a more beautiful exposure because more you will remove the insula, more you will be able to lift up the surface of the insular cortex, speaking about the pia mater. And finally, in the end, you will have all pia maters, because you can do that, of course, at the level of the superior temporal gyrus also, around the Sylvian vessels. And in the end, you have a beautiful view everywhere without touching never any vessels. So the sole question will be finally where to stop into the depth. And now the answer is the temporal stem, because the I4 is running at this level, just the anatomy, in the left, naming your task, in the right, mentalizing non-verbal semantic association task. And when you will stimulate and induce a transitory deficit, that means that if you push more, first of all, you will cut the I4 and you will induce permanent deficit, and sometimes without being aware about that, especially in the right so-called non-dominant hemisphere. But second, you will take at that time a risk to be into the contact of the perforating arteries, because of course, as we know, the temporal stem is the lateral part of the anterior perforating substance. And this is the reason why if you accept to leave this pathway, so that means to be harnessed more or less with the anterior perforating substance 4 to 5 cc, so subtotal resection, never you will have any problem anymore. It's exactly what happened these past 10 years in my experience, why I had 2 problems when I was younger in the first 10 years, and among only, if I can say, at that time, 50 patients, why I did much more. So my rate of permanent deficit was around 5%, like in the classical literature. Today, in the past 10 years, by applying what I told you, is 0%. And if I can do that, you can do that, because you see, you don't need to be Yazargil and to split the Sylvian fissure despite so many vessels, veins, and so on. It's the reverse. I am not a surgeon. I'm just a scientist. I know more or less when I am and where I am into the brain, and then you can forget the technical issues.
Thank you very much.
Any more questions from the panel? No more questions?
No.
Let's see. We have one more. Yeah, we have one more question here. For you, it's much more important the age limit or the Karnofsky performance status when you decide to do a surgery?
Of course, the Karnofsky and the cognitive scores. I mean, I did this kind of surgery in patients with 70. And of course, it's a selection once again, because the brain plastic potential was still efficient in this patient. So a very good Karnofsky, despite the fact that they were old for me and not 20, 30 or 40. So the age is not a contraindication. But of course, more you have tendency to become older, more brain plasticity decline. So it depends on each patient. While if the Karnofsky is just 50, that means that except if it was a mass effect at the level of the brainstem, as we discussed already, you have more or less no chance today to restore the brain. It's too early. So this is the reason why, finally, what I proposed today is very humble, is just to preserve the brain, because the brain is processing more or less almost normally before surgery, but not to restore it. It's too early. We have to better understand these mechanisms of neuroplasticity.
Perfect. So, okay, Professor Duffau, was a great pleasure to hear you. Really, we thank you a lot. And I want to tell to everyone that on behalf of Dr. Sokolovsky, Chair of the Department of Neurosurgery of the University of Buenos Aires and of the Oncological Neurosurgery section, and of myself, we thank you, all of you, by being today with us. And thank you. Thank you, Dr. Duffau, again, and see you next week. Okay?
Thank you so much for your invitation.
Thank you very much.
For the very exciting discussion. And of course, take care.
Take care.
Thank
okay,
you.
be safe.
Take care. Bye-bye.
Okay.